Oh, there are so many of them now, fertility treatments, starting from simple timed intercourse where the couple is given some ovulation induction medicine where the lady produces multiple oocytes or follicles, and then they are given a trigger for ovulation and the couple have a simple intercourse and they have a fairly good chances of pregnancy. This is called timed intercourse. The second one is IUI, which is where again the lady is put on ovulogents, where she is given either injections or oral medicines to produce multiple oocytes, and then the husband gives a semen sample provided the fallopian tubes are open, and we prepare the semen and take the best sperms out and we insert it inside the uterus. This is called intrauterine insemination, where the sperms are put close to the oocytes around the time when the lady ovulates. And the third one is IVF, which is called the in vitro fertilization. Means in vitro means the eggs and the sperms are fertilized in the lab outside the human body, and the embryo which is produced, which is again transferred in the woman's womb, and after 16 days we see the results. And then the fourth treatment, which is the last and the most highly technical one, is ICSI, when there is a male factor, mainly when there is a male factor, when the sperm count or the motility is very low. When we do an ovum pickup, the lady produces multiple oocytes which we take it out through a vaginal route under ultrasound guidance, and in the lab we inject each sperm inside the ovaries, we inject them. So this is called intracytoplasmic sperm injection or ICSI, and make the embryos. So these are basically the four types of preparation. IVF or infertility has a lot to do with the emotions, and it is mainly how you counsel the patient. The patients are counseled very well. पेशेंट्स लोगों को बताया जाता है, अगर पेशेंट शुरू से जानते हैं कि उनका क्या प्रॉब्लम है, कि उनके प्रॉब्लम किस लिए वो लोग आ रहे हैं, वो लोग मेंटली प्रिपेयर्ड रहते हैं. तो अगर पेशेंट्स को डार्कनेस में नहीं रखा जाता, जैसे हम क्या करते हैं, व्हाट आई डू राइट फ्रॉम द डे वन द हस्बैंड कम्स इनसाइड द दिस थिंग एंड ही नोज उसकी बीवी का कितने फॉलिकल्स हो रहे हैं, उसका सीमेन कैसा है, उसके चांसेस कैसे हैं, व्हाट इज द कॉस्ट. It has to be very important that the couple is very transparent about the cost right from the beginning, because IVF is an expensive affair. So they can be prepared mentally, emotionally, financially, everything they are prepared. So right from how many oocytes they have got to how many embryos they have prepared and what are the success rate. So these things have to be told to the patient, and then I think they can, because most of the patients are educated these days. So they know about it, and patients who come from the districts and the villages who are not educated, you have to tell them that dekho, these are the chances with your own eggs, these are the chances when you go for a donor's egg, these are the chances when you go for donated embryos. The patient should know everything. That is it. Now with the media and internet and social media, patients are much aware than what they used to be 20 years back. So they know mainly, but the feeling that IVF में normal बच्चा होगा तो कुछ अलग जैसे दिखने, that was used to be there initially, but now patients are aware that IVF is a place where you can have a child as normal as any other person. There's nothing different. Initially people used to hide, they didn't tell people around that they had an IVF baby. Now patients are very open, and in fact they post in the Facebook the name of the clinic and the doctor, how happy they are to have a child and all. So this misconceptions are gradually decreasing. Then after an embryo transfer in an IVF, patients used to think initially that we can't move for 16 days, we have to just lie down, we can't get down from the bed, we will not have bath, we don't climb stairs, you need an American commode for this thing. But now these misconceptions, patients are going back to work after 3 or 4 days, they are leading normal lives, and they are taking their medications on time. They know that there is no need for a bed rest, and you are not ambulant anymore. They know that you can move and yet still conceive. It's all about the embryo quality and the endometrium quality. It's the dialogue between the endometrium and the embryo. Initially, patients used to try from the fertile period, that is day 12 to day 14 or 16, and that used to cause so much of a emotional turmoil. The couples, most of the couples, the husband and wife both work. So fixing up a day, like on day 12 we'll have to have intercourse, and on day 15, those things are gone, They know that a PCO lady can even ovulate much later in her cycle. So that is another misconception. There are a lot of such misconceptions which, I'm sure about the goodness and the badness of the internet, the goodness and the badness. But after all, it is the mental and the physical health of the couple which is extremely important in getting a success also. The main thing about the lab is the man behind the microscope. A good embryologist is something, and the lab is known as the temple of an IVF clinic. The lab is usually known. So it has to be very, very clean with a bunch of very, very conscientious embryologists who have to keep the place clean, who have to keep the records very clean, because there are multiple patients. So you just cannot mix up patient's sperm and eggs. That is one of the biggest criminal things you can do. So what we do is we are very, very strict about the record keeping and the naming of the dishes, and we have incubators which mimic the human body. That is where the sperm and the eggs are incubated. So opening of the incubator doors is something which is very important. We don't open the incubator doors at random. Cleaning of the place. You cannot clean a lab with the typical phenyl. That lab, the sperms and the eggs are very, very delicate things. And the embryologist, she just cannot come in the lab with perfume or lipstick and all these things. You must have honest embryologists, who will come and report to their seniors about what mistakes they have done, so that they can sort it out together in a team. There should be a peer relationship is something. When I was trained in 1998 in Singapore, we had separate classes on relationship with peers. You can't have ego hassles, you cannot divide work ki isne zyada kaam kiya, maine kam, and ye nahi hona hai. There should be a good camaraderie between all of them. Then a lab can work, then the labeling and witnessing. When you are when there is a oocyte and you inject the husband's sperm or inseminate the husband, there should be another fellow embryologist who will be standing next, who will see that yes, the correct person's sperm has gone to the correct egg. So this is called witnessing. These small things, make a lab very different, that's it. My only USP is that I, being a medical doctor, I have been trained in embryology. That is the only thing which is different. Way back in 1998, I was trained in embryology. So my USP is that I can see the follicular bit, that is in the clinics, the size of the follicle and the endometrium, and I can come to the lab and see the same embryos. So that is where I see both the bits, the entire thing. So I'm sure it is, the other labs are also good, no comparing with any of my fellow colleagues. They are equally important in my life as everything else is, but my USP is that I do the clinical bit as well as the lab bit, both, so I can correlate.